Hello, everyone, and welcome to our program, Science Sealed Delivered. This is the second part of a series looking at evolving treatment options for the management of perianal fistula in Crohn's disease. This activity is jointly provided by Partners for Advancing Clinical Education and Bonum CE in partnership with MondayNightIBD. This program is sponsored by an educational grant from Takeda Pharmaceuticals. If you haven't already completed your pre-survey, please do so by clicking the link in the chat or scanning the QR code in the top right corner of the screen, and please complete that before we start. Let us know who you are in the polling question on the screen, and please be sure to complete your evaluation at the end of the session and claim your free CME credit. And also, please make sure you join us on Monday Night IBD for live Q&A with the IBD expert and our guests on Monday, February 13 at 8 p.m. Eastern Time. This is when you'll have the opportunity to ask Dr. Dubinsky, Dr. Lightner, and Brandon, who's joining us today, all the questions that you want answered regarding the topic of Crohn's perianal fistula. I'm Dr. Charabaty. I'm the founder of Monday Night IBD and a IBD gastroenterologist at Johns Hopkins Sibley Memorial Hospital. And I am joined by IBD expert extraordinaire today, Dr. Marla Dubinsky and Dr. Amy Lightner, and by our fantastic patient advocate, Brandon. Thank you so much for being with us. Brandon Pomish is a patient living with Crohn's disease and perianal disease, and he will be sharing with us his experience living with the disease and treating it with stem cell therapy. Marla, welcome.
Thank you so much for the invitation to participate.
Thank you for being here, Amy.
Thank you. Really wonderful to be here.
And Brandon.
Thank you. It's great to be here, to be able to share my story.
Thank you, everyone. Our disclosures are shown on the screen. At the end of this education activity with these fantastic people, we should all be able to really describe the health burden and psychosocial effects of Crohn's perianal fistula in patients living with this condition, review the current best practices for the management of CPF, and assess the unmet needs in the care of CPF that is refractory to current medical and surgical therapies. And finally, evaluate the emerging treatment options for patients living with Crohn's perianal fistula or CPF. So our agenda for today, I will review the prevalence and the nature of perianal disease in Crohn's patients. And then Dr. Dubinsky will review with us the initial management of CPF and the importance of multidisciplinary care in CPF. And then Dr. Lightner will review the management of complex CPF after medical failure, after biologic failure, with a focus on stem cell therapy. And finally, we'll hear from Brandon Pomish about his perspective on living with CPF. So let's start by reviewing Crohn's perianal fistula or CPF. How big is this problem? This is data from a systematic literature review and a population-based database analysis that shows that up to 55,000 people in the US live with Crohn's perianal fistula. The incidence, the risk of developing CPF increase with the duration of the disease, and up to 20% of patients with Crohn's disease will develop perianal disease in the course of the disease after 10 to 20 years. The good news is that the incidence of perianal disease has decreased in the biologic era. As you can see here in the graph, in red, you have patient diagnosed after the 90s when biologic became available versus the incidence that we had in blue before biologics were available. When we're talking about CPF, it's very important to distinguish a simple fistula from a complex fistula. And for the rest of the session, we're really focusing on complex fistula. What is a simple fistula? It's a low fistula that's really not involving the sphincters. It has a single external opening, and it's not associated with an abscess, with an anorectal stenosis or rectovaginal fistula. The opposite spectrum, we have the complex fistula. These are the high fistula, they involving the anal sphincters. They can have multiple opening and be associated with an abscess, with an anorectal stricture, or with a rectovaginal fistula. Now, unfortunately, in patients with Crohn's disease, most fistula are complex, and these complex fistula have actually a worse prognosis than a simple fistula. Complex fistula are more likely to require medical and surgical management. They are less likely to heal, And when they heal, they are more likely to recur during the disease course. It's estimated that overall 37% of complex fistulas are in remission, as opposed to 66% of simple fistula during a median follow-up of 10 years of patients with Crohn's disease. Now, most recently, a group of experts got together and put together a new classification for CPF. And this classification is very important and interesting in how, when we're moving forward in future clinical trials and in guidance in terms of how to approach and treat these fistulas, because this classification takes into account not only the anatomy of the fistula, but also the presence of intraluminal disease, the health of the perineum, the symptoms of the patient, and the disease burden. And again, this classification is intended to guide clinicians on how to address and treat CPF in particular patients. So class 1 of CPF is minimal disease with minimal symptoms and minimal anorectal disease burden that require minimal intervention over time. Class 2 is the chronic symptomatic fistula. This is a fistula that will require medical and or surgical intervention, and the goal is to achieve perianal fistula closure. This is class 2A. Class 2B, our goal is to use medical and surgical therapy to control symptoms. And class 2C, this is when the symptoms are so debilitating that they require a diverting ostomy. The class 3 is really talking about severe disease with an exhausted perineum. This is when patients have severe symptoms despite an ostomy with irreversible perineum destruction that require a proctectomy. And the class 4, this is when patients have perineal symptoms after proctectomy, mainly related to the sinuses and the wounds, and they require medical and surgical therapy for sinus closure and for symptoms control. So I'm going to stop here and hand the mic to Dr. Dubinsky.
So here I'm going to present the Toronto Consensus on Goals of Treating Chronic Perianal Fistulizing Disease. This details sort of the outcomes or what we want and defined as success for medical management. One, starting with complete remission, which is symptomatic and radiographic remission. Symptomatic remission defined as absence of both pain and drainage from the fistula tract. Also noting, going to the radiographic remission before I go back to symptomatic response, but the idea of absence of any inflammation in any fistula tract and absence of any abscess. And probably what most of us see, which is really what is a meaningful symptomatic response, which is the improvement in symptoms of pain and drainage judged by both the physician and the patient. So what are some of the approaches? We know that when there's pain, there's pus, and Amy's going to talk a little bit more about, where we need to partner more closely with our colorectal surgical colleagues and understand when abscesses need to be drained. So there's a pictorial here showing you this image of a ceton, and the reason why that is that first we're removing the pain, having an incision and drainage, and being able to support that with the addition of ceton, which is really a cornerstone of the surgical approach, which, as we know, maintains the patency of the fistula tract. So it's there to keep it open and drain so the patient doesn't get recurrent abscesses if one part of the fistula tract closes. And the goal really is to maintain the integrity of the anal sphincter. So really that's why you need an expert in this area of perianal Crohn's disease. And we all know that we want to work with our colorectal surgeons and sometimes talk to our patients about what types of surgical colleagues we would like them to see. There's a reason for that, because this is really an important part of the management. When we talk about treatments such as antibiotics, I'm going to talk about what we know about monotherapy, meaning just antibiotics alone. They are widely used, but again, I think that when you drain the pus and you get rid of the infection and you've had a ceton in place, is there really a role for antibiotics? So I do want to ask Amy's opinion on how she approaches that. But also we know that biologics alone are not necessarily the end-all be-all solution, and that there has been data to support that biologics in combination with an antibiotic has a more durable effect. And we're not just talking 2 weeks. We're talking about really a long-term exposure, or longer than your typical 10 or 14-day antibiotic exposure. Immunosuppressants, particularly focusing on thiopurines and tacrolimus, Overall, it does look like there was a significant difference in the use of thiopurines in a meta-analysis. Now, the question is, again, since we're moving away from thiopurines purely as monotherapy, do they add value in combination therapy? And again, I think that's also an important question that I get asked a lot, since I'm a big monotherapy biologic kind of gal, is the idea is that are there certain subsets of patients, particularly perianal, where you would actually use combo? So that is a good topic of discussion. And here is the fistula improvement put forth on the use of tacrolimus versus placebo. There appeared to be some improvement, but similar rates of remission. Now, as we know, the only biologic actually approved for perianal fistulizing disease, which was a randomized controlled trial, is infliximab. There was definitely improvement, particularly defined. Remember to always look at the definitions in the trials: 50% reduction in number of draining fistulas, at least 2 consecutive visits apart. And you can see here there wasn't a difference in dosing of 5 versus 10, but we've come a long way in understanding therapeutic drug monitoring, which is for another day. But in this particular concept, the idea is that there didn't appear to be a dose response in the definition. Now, we've all moved towards different definitions. And just as a reminder that in the studies that have looked at biologics plus the surgical approach of cetons, it did show that there was less time to recurrence and less time to additional intervention. So again, it looks like biologics plus antibiotics and biologics plus ceton appear in this moment to be, based on these studies, to be superior to biologic alone, for example, or antibiotic alone. Additionally, I did want to highlight for you the TNF data, because that's the one we sort of rely on more so in our thought process around the use of anti-TNFs in perianal fistulizing disease. And you can see here that with infliximab, healing and closure were definitely a dose response, that if you had higher concentrations with both adalimumab and infliximab, you achieve better healing. When it comes to the other studies, what I wanted to comment is that no other study actually did a randomized controlled trial. What they did were retrospectively looking in the registration trials at those patients who also had perianal fistulas when they came in, but they also had luminal. Retrospectively, we've published on that subset and commented that drugs like adalimumab and also with ustekinumab, that there was a benefit. Again, was not powered, was post hoc. We all have to take that into consideration when we think about what to best apply. This is a good publication, so if you want to take the reference down to really start to dissect into where the studies have shown healing versus improvement and the differences we see. Even vedolizumab, it was a study that was actually cut short, but upon early indication, there was some data to support that vedolizumab did have a positive impact. Again, this was a small study because it was terminated early. So just keep that in mind when you're also looking at the data. So this was an interesting publication recently put out in Lancet GastroHep from the European group. They took patients, they all had a ceton, then they were added anti-TNF in combination with thiopurines. They had a group where then they removed the ceton and saw what happens if you just carry on with medical therapy, for example, versus those that underwent a more definitive surgical approach, such as an advancement flap. Obviously, you need normal rectal mucosa to do that, so there is some caveats around that, or litigation of the intrasphincteric fistula tract, and look at, after they remove the ceton, re-intervention-free survival, meaning if you just stuck with our typical medical plus a ceton, does that do as well as needing to come back in and do something compared to if you do something more definitive? And what you can see here, interestingly, recurrence-free survival were the same, but re-intervention-free, where you needed to go back in and do something, was less so in those where you had a more definitive surgical approach. The same Toronto consensus group did put together a nice sort of algorithm or flowchart for us to sort of think about, when do we bring antibiotics in? When do we bring in investigations like MRs, for example? When do we bring our surgical friends in to think about an EUA? And like I said at the beginning, if there's pain, something needs to be drained typically, and to partner with your surgeon and decide if they need an MRI or whether we can go straight to exam under anesthesia, for example. And what do you do after that? So I'm now going to turn it over to our surgeon, who's going to walk us through and maybe, Amy, highlight along the way some of the things that I sort of want to know more from you about how best to approach patients.
Yeah, thank you, Marla. So just as Marla was saying, it really becomes a multidisciplinary approach. So when we think about when we're first seeing a patient as a surgeon, a lot of times they've come from a gastroenterologist. So we want to follow up with our gastroenterologist and say, you get an assessment, a lay of the land of what medications has the patient been on, what's their luminal disease status, if they recently had a colonoscopy, if they recently had cross-sectional imaging. We want to gather all that information to really understand where their Crohn's disease is beyond just the fistula in isolation. And then when we're meeting the patient for the first time, as we already heard, it's good to set expectations because these are patients we're going to be seeing over a long period of time. So as a surgeon, these are patients we're going to see multiple times typically in the operating room. So you want to develop a rapport with the patient to understand what are their symptoms, what are the most concerning symptoms, what are the expectations of treatment. And then typically it's deciding, we get some imaging or we go to the operating room and do an exam under anesthesia to start. And some of that will have to do with what we see when we're first examining the patient in clinic. So we have that discussion with the patient. We understand the medical aspect in conjunction with our gastroenterologist. Then we examine the patient in the clinic just to get an idea. Are there cetons in place? Does it look like there's external openings? And based on that exam, if there's multiple external openings and you think that perhaps you want some more imaging before you go to the operating room, you can get an MRI. That's really considered the gold standard of imaging when we think about imaging these perianal fistula patients. A lot of times we'll go straight to the operating room to do an exam under anesthesia. And the idea of that is really to understand the anatomy, put cetons in if we need to, drain any abscesses that might be there, and come up with a treatment plan going forward based on what we've found. And so the idea, Marla was just talking about putting these cetons in conjunction with medical therapy. The cetons are to allow things to drain. And the question with antibiotics, I agree. Antibiotics can be useful before going to the operating room, but once we've gone to the operating room and put a ceton in and the patient is draining, I typically will take the patient off antibiotics unless they were getting a lot of symptomatic relief. The challenge with complex perianal fistula is that we have a lot of surgical options, but those surgical options typically don't work that well unless a patient perhaps has no proctitis and has one opening. But here we're going to focus on the patients that may have some proctitis, they may have multiple fistula tracts, and what are our options for these patients? Because most patients with perianal fistulas will continue to have some sort of symptoms or refractory disease with their fistulas. It's quite high. And so despite all the medications that we use, and despite numerous surgical interventions, up to 37% of patients will actually have refractory disease and have multiple trips to the operating room and have a lifetime of disease with perianal tracts and symptoms from their perianal disease. And partly that's that Crohn's fistulas are quite different than cryptoglandular. So a non-Crohn's fistula, which we call cryptoglandular, there's not proctitis, there's not inflammation. When we think of Crohn's related fistula, it's a phenotype of Crohn's. So it's that transmural inflammation. So you start with an ulcer in the rectum or in the anal canal, and that ulcer really burrows its way out to an external tract. So the idea is there's a lot of inflammation at these fistula sites, there's ulceration at the fistula sites. Over time, the chronicity will cause the tracts to epithelialize, but typically it starts with that acute inflammation, which is different than cryptoglandular fistulas. And so when we think about stem cell therapy and the use of stem cell therapy in Crohn's perianal fistula, it's important to understand the pathophysiology of the fistula to understand why mesenchymal stem cell therapy can be effective. Because there have been trials done using MSCs or mesenchymal stem cells in cryptoglandular non-Crohn's fistula, and they actually don't work all that well. They have much better results in Crohn's fistula. And it's likely related to what MSCs are, how they work, what the etiology of their mechanism is. And so when we think about mesenchymal stem cells, MSCs, whether they come from adipose tissue, whether they come from bone marrow, the function of the cell is really, it's an anti-inflammatory, it's an immunomodulatory, and it's a repair cell or wound healing cell. And so Crohn's fistula, there's inflammation there. There's immune cells that perhaps we don't want in certain concentrations in that local environment, and there's a wound. So MSCs address those three things. First, it's a potent anti-inflammatory, immunomodulatory. We actually see the ratio, for example, of T regulatory cells change in the local environment after we inject MSCs. And then third, and importantly, it's a wound healing or a tissue regeneration. And so that function of MSCs translates into Crohn's fistulas quite well. And that's why we've really seen it be consistently used in Crohn's disease rather than cryptoglandular. And so how do we get MSCs and where do they come from? And we get a lot of questions about, are these embryonic stem cells? Are they from umbilical cord tissue? Mesenchymal stem cells are a healthy adult stromal cell. So some people will call them mesenchymal stem cells, others will call them mesenchymal stromal cells. So it's a repair cell type. They typically will come from healthy donors. Sometimes they're autologous and will come from the patient themselves. But in terms of the clinical trials that we're seeing now, most of them come from healthy donors. And they can come from fat tissue or bone marrow. Fat tissue will do liposuction to obtain the fat tissue. And then once that tissue is obtained, it's taken to the lab. And the MSCs are isolated from that tissue and then expanded. Bone marrow, it's typically an 80 cc or 80 mil harvest from the iliac crest. And from that 80 milliliters, we then again take it to the lab. We isolate the mesenchymal stem cells from that and create these master cell banks. So typically from one healthy donor, we may get enough for 100 to 200 doses of cells. So that means that we need a lot of healthy donors, and we rely on healthy donors to continue to donate to create these cell banks. And the cells get extensively tested, as you might imagine, before we can use them in clinical grade or in human use. So the cells get isolated, they get sent off for testing, and then once the testing comes back, they can be expanded and frozen down for use. And then once we have these mesenchymal stem cells, how do we use them? So a patient comes in, and we'll hear from our patient advocate soon about the treatment, but what is it that we do? So it is meant to be a very straightforward surgical procedure that can be easily taught. We try to make it as minimally invasive as possible. So not a lot of intervention. We don't want to put the sphincter at risk, especially if there are multiple fistula tracts. So what we do is we will take the cetons out at the time of mesenchymal stem cell delivery, and we'll really curate that tract, which just means we debride it or try to de-epithelialize it to get it to have healthy tissue that will then come and stick together. And then we close the internal opening with just a simple figure of 8 suture, usually a 2O PDS suture that's absorbable. And then after that internal opening is closed, we'll check that it's closed by using a probe and injecting some saline, make sure it's all cleaned out. And then we typically will put about a third of the dose at the internal opening and the remaining 2/3 around the length of the tract in parallel to the tract of the external opening. Now, if there's multiple tracts, obviously we kind of divvy up that dose, but it's a small area, relatively speaking, so we can get a small amount of volume, about 10 milliliters to 20 milliliters in that perianal region. And so it's a simple procedure. We'll put in a nerve block afterward. Patients are discharged after a couple of hours. We do send them home usually on a couple of weeks of antibiotics after the procedure. But the idea is that it's simple, outpatient, no risk to the sphincter, minimal pain, minimal discomfort, and so that it can be patients go on their way and they get evaluated per the clinical trial on an ongoing basis. In general, MSCs themselves are pretty well tolerated. MSCs do not have an HLA class 2 antigen, so theoretically antibodies should not be generated. That has been looked at in studies, and some patients will develop a small antibody response, but we've determined that's not clinically significant. The reason that is relevant is if patients have repeat treatments, we want to make sure they're not developing antibodies to a certain cell line from a certain donor. It's been extensively looked at whether MSCs are tumorigenic, because in A long time ago, there was concern about that. That has never been borne out to be true. So we are no longer worried about tumorigenic characteristics of MSCs. And it's really important when we apply these MSCs, this concept of pre-surgical conditioning. And what that really means is putting cetons in when patients have sepsis, taking those cetons out when they come for their MSC delivery. And the most important thing is really de-epithelializing that tract. And the way I explain it to patients is if you have your ears pierced and you take out your earring for a couple of months, you can put it right back through because that hole is epithelialized. So we have to make sure that we scrape all that epithelialization off before delivering the mesenchymal stem cells. Now, what about the study? So what does the data show on MSCs? The first patient ever treated was actually in 2003. It was a patient with a vaginal fistula in Spain. Dr. Garcia Olmo treated that patient. And that single patient had had medical treatments with infliximab and multiple other medical intervention, did not heal. She had multiple surgical interventions, a gracilis flap, nothing had worked. And they did a simple injection of adipose-derived mesenchymal stem cells, and she did very well. She healed within a month. So that single patient really generated a lot of enthusiasm, a lot of clinical trials on this topic. So just to highlight a few of the clinical trials that have since been done. This is a trial in 2013, and it was a phase 1/2 open label, single arm clinical trial in Spain. 24 patients were treated, and the efficacy was really at week 24, and that was a combined clinical and radiographic efficacy. And they found that complete closure was achieved in almost 60% of patients, which was quite high. And some of this laid the groundwork for the phase 3 trial that was later done that we'll talk about in just a minute. Another trial in the Netherlands was 21 patients. They were double-blind randomized treatment to placebo. And fistula healing in this trial was observed as early as 6 weeks. And they noticed, interestingly, after a single injection of MSCs, that the healing was actually maintained through week 24 and then later follow-up. This trial actually went on to do follow-up for 4 years. And interestingly, this has been the longest duration of follow-up. Even though it was a small number of patients, patients that had healed initially remained healed out to 4 years. So really interesting data that the patients that do heal are not getting recurrence of disease as we often see. Why that is the case, we don't necessarily yet know, but hopefully it's something that we can determine in later studies. So the one phase 3 clinical trial that has now been done, Admire, this was completed in Europe and Israel. It was a phase 3 randomized double-blind placebo-controlled trial of nearly 300 patients. Patients were randomized 1-to-1 placebo to treatment, and treatment patients got 1 dose of 120 million MSCs. These were adipose-derived. They were flown fresh to clinical sites from where they were manufactured. And the primary endpoint was combined clinical remission and response. These were for adult patients. They had to have a CDAI score of less than or equal to 220. So the idea was patients without proctitis, without a lot of luminal involvement, on pretty stable medical therapy. They obviously continued their medical therapy, but they have to have draining complex perianal fistula, a minimum of 1 internal opening, maximum of 2 internal openings and 3 external openings. So patients with more than those 2 or 3 tracts could not be enrolled. Patients with proctitis, anal canal involvement, or diversion were also excluded. So a bit limited, but patients could still have some active disease and more than 1 tract. And so what they found at week 24, this combined remission rate, was that there was 53% clinical remission and 66% response. So much better than what we can get when patients have multiple tracts with other surgical intervention that we do. And importantly, it was very safe. So there were no adverse events or serious adverse events related to investigational product. And the most commonly reported adverse event was pain at the site and abscess at the site, which was a very low rate and was equivalent in the treatment and control group of 12% and 13%. So what we would expect with perianal Crohn's involvement, and again, unrelated to investigational product. So the safety profile looked very good on this. When they looked at the longer term results, out to 52 weeks, the question was, can this healing rate, this significant improvement, be maintained out to 1 year? And the answer is yes. So the patients that had healed at 6 months stayed healed out to 1 year. So there was still a significant improvement in perianal fistulas after a single injection of mesenchymal stem cells at 52 weeks. So very encouraging that the healing seems to be durable over the long term. So what about current ongoing studies of MSCs? There's a current ongoing study of phase 3. This is ADMIRE-2 that's being done in the United States. And they've actually completed enrollment. So we should see an interim analysis soon. And that would give approval of adipose-derived MSC product in the United States for perianal fistula. There's also another European study designed to capture the real-world efficacy after that initial ADMIRE study. And then we put together a group of phase 2 trials here in the United States because there were a lot of patients that would come to us that didn't meet inclusion of the ADMIRE trial because perhaps they have proctitis or anal canal involvement, or they were diverted, or they had a vaginal fistula. We really wanted to include those patients where we really don't have other surgical treatment options and be able to enroll them in a clinical trial. So using bone marrow-derived MSCs, we completed 3 phase 2 trials. One was complex perianal disease, meaning more than 2 or 3 tracts, and proctitis and diversion. A phase 2 trial of rectovaginal fistulas, and then the third trial was a pouch fistulas, so a Crohn's-like phenotype of a J pouch. And we completed those trials, and they'll soon be in publication. But I can tell you the perianal, the complex perianal fistula, we had about 83% healing, vaginal 50% healing, and pouch 50% healing. So there certainly is a role, even in these patients with really complex disease that we don't have other options for. And these are the patients that will typically have a diversion or a proctectomy and a permanent stoma, that does seem to be a role for mesenchymal stem cells in these really advanced phenotypes. And similar to what we already talked about, this is just a pictorial of how we do the injections. We receive the mesenchymal stem cells from the lab or from industry. We'll close that internal opening, like I said, with a figure of 8 suture. And then it's a simple direct injection. We use a 22 gauge needle because you want to use a wide enough needle that you don't get shearing forces causing cell death. So they've been tested in 22 gauge needles. So that's what we use to inject. And then do that simple nerve block afterward to alleviate any pain after, and then send the patient home. And we follow the patient clinically, but also with MRI. So these are a couple of examples from the clinical trials of what the MRIs look like before and after. On the left side is a case of before and after where the patient did not have response. So the top picture, you can see the fistula there. And on the bottom picture, persistent fistula tract at 6 months. Whereas on the right is the second patient example on the top. You can see the fistula tract there before mesenchymal stem cell therapy, and then afterward, you can see this is completely resolved. The challenge of using MRI in clinical trials is that even when you heal, there still will be a scar there, and that scar lights up on MR. And so it may still look like a fistula tract is there. So most of the clinical trials will use an MRI healing definition of no fluid collection greater than 2 centimeters in 2 of 3 dimensions, meaning that there's really no fluid there. There may still be a light of a tract, but we don't want to see inflammation and fluid. But that's the tricky part about using MRI in these trials. So in summary of mesenchymal stem cells, there certainly are candidates in Crohn's population for mesenchymal stem cell therapy. And I think that we're seeing these candidates in the phenotypes expand into really severe perianal disease, vaginal involvement, and now even J pouch involvement. And it's really because the adipose and bone marrow-derived MSCs have these anti-inflammatory and immunomodulatory and tissue repair characteristics. And this is what makes them so useful in Crohn's fistulas specifically. And fortunately, the therapy is very well tolerated. They're not side effects. There doesn't seem to be much antibody formation. Patients do quite well. And it's exciting that phase 3 data has really established this as a therapy that is significantly improved to placebo. And hopefully future trials will include some of these other phenotypes that we're now starting to treat with MSCs. So I'm going to hand it over to our patient advocate who did receive MSCs to tell his story. I'm very excited to hear from him, and thank you for the opportunity to present.
Thank you, Amy. Before we go to Brandon, I want to thank you both. First of all, Marla, for the tour de force of reviewing best practices and best treatment for CPF in less than 10 minutes. And Amy, for walking us through stem cell therapy for CPF, really making it simple for us how MSC works, what the process is. And thank you for reviewing the data with us. And I agree, this is very exciting and it would be fantastic to offer this therapy to our patients who have a refractory CPF. We're very excited to have Brandon with us today. Brandon, you were gracious enough to talk to me offline and share with me your journey and all the struggles that come with that journey of living with CPF. And you were on different medical therapy, you underwent different surgery, even an ostomy, and you continue to have symptomatic perianal disease that was really affecting you physically, emotionally, socially, and we'll talk about this. But before we talk about how perianal disease affected your life and how things change after stem cell therapy, I really want you, from the patient perspective, from the person receiving the stem cell. We heard from Amy about the process, but we really want to hear from you. How did this day go? What happened during that day, and what was your journey like?
I had liposuction, and I arrived at the hospital in the morning and had the liposuction performed. About 2 hours later, the stem cells were ready. So I was put under again and injected with what the doctor said was about 5 million stem cells, and I had 2 external openings. So they had about 5 million cells cultured after a couple hours. The experience of the liposuction was certainly the worst of the symptoms of the procedures. The actual injection sites were similar feeling to what it feels like they have a ceton in. A little bit of sharp pain, but it didn't last more than a week. The liposuction procedure, I had to wear a pressurized suit for a month, 24 hours a day. So my body was pretty bruised up, and the effects of that were about that month until I was able to take my pressure suit off. About 4 months later, I went and received an MRI locally, and it showed that one of the 2 tracks had healed, which was very exciting. I always knew from the beginning that I was going to need to go for 2 injections. That was known up front. So about 3 months after that, so 7 months after my first injection, I went back into the hospital. By then, they had cultured about 50 million cells and injected into the 1 opening. And from that, it was the same, just a little bit of pain, similar to a ceton. And I went home. And about 4 months after that, so 11 months total, I got another MRI that showed complete healing, as Dr. Lightner described in the MRI, of my fistula tracts.
You know, this is great to hear from your perspective. Tell me what happened after this. So I know the MRI looked like showed that the fistula had closed, but also symptom-wise, you know, what happened? What symptoms were there that bothered you, that were gone, and how did this, you know, what you were sharing with me, it changed your life?
Yeah, so I think I experienced some of the things that Dr. Lightner was explaining. I actually had a little more bleeding after the second injection, and was pretty nervous. Thought that maybe this had failed, but ultimately it did prove that it did close. So it was scary and exciting at the same time.
And what are the symptoms that you were having before with a perianal disease, with a perianal fistula that resolved for you? And how did this, change how your daily life?
Right. So it started with an abscess, kind of the same track that Dr. Lightner was explaining. Cut and drained several times to no avail. Had setons and Penrose drains, antibiotics, ostomy diversion, biologicals, all of that in a span of 2 years before I researched and experimented with the stem cells. So, every aspect of my life was changed. I had a business to run. I was married. I had an 8-year-old child, 8-month-old child at the time. So physically, sharp, intense pain all day long, all night long. I had to wear Depends 24/7, change them constantly because of the draining and bleeding. I'm an active person. So, all activities and sport pretty much stopped. I could, muster up to walk around to the end of the driveway and back, and that was about it. Constant nausea and fatigue. There's no comfortable position when you have these drains and that type of pain. So those are a few of the physical side effects. Socially, all of my social activities pretty much stopped. I was on a bunch of boards and committees, nonprofits and such, and that pretty much stopped. Lack of intimacy with my partner. I couldn't be a father to my daughter and do normal things like get on the ground and play and do normal, even pick up my child most of the time. So it was tough. And then mentally and emotionally, you constant operations, you have pain medications, doctor's visits, and you have this depression and this displacement from reality because that is your life. And anything else that's going on just isn't relevant. This is the only thing that you can focus on because the pain reminds you. And you kind of have a no light at the end of the tunnel outlook on life. After all the surgeries, after the doctor's visits, when you're in the office and the doctor, and I've seen some of the best who have given you the best medical management possible, kind of say that this is it, you kind of lose spirit. And the stem cell procedure gave me that light. Even the opportunity to go for it gave me that light, gave me a year of hope, and ultimately was successful. And the stem cell procedure gave me back my life. It set me on a course, to not only have those wounds healed and have my ostomy reversed, but live again and be able to share my story and help other patients who are going through it, because it's awful.
Thank you, Brandon. Thank you so much for being so brave and generous to share your journey with us, because I know it is not easy to talk about this, but really appreciate you sharing your experience. And I think for us clinicians to be reminded that perianal Crohn's disease is not just a diagnosis. It is a complication of Crohn's that affects someone's life at so many levels, like you shared with us, at the most intimate level to social to professional. So I think it's very important for us clinicians to be reminded of that, and you just did that. And we're so excited for you that you're doing better and that your life is back on track. And thank you again for sharing your journey with us. We know it's not easy to relive these moments, and we really appreciate the fact that you were willing to do that.
Thank you for the opportunity. I love it.
All right, so I think this concludes our fantastic program. I know we didn't have too many physician to physician discussion because we're saving that for our live Q&A. So make sure you are joining us for this live Q&A with Brandon. Brandon will be there too with Dr. Dubinsky, Dr. Lightner on Monday, February 13 at 8 p.m. Eastern Time. That's 7 p.m. Central Time, 5 p.m. Pacific Time. You can start posting your question below this video, and or that Monday on February 13, post your questions. We'll be there to answer them. And I am looking forward to a very lively and educational discussion on that Monday. So thank you again for joining us. Please make sure to claim your CME credits by completing the post-test and evaluation form at the link on the screen. And make sure to follow us, Monday Night IBD and Bonum CE on Twitter to stay tuned for more CPF content.